Welcome, everyone. The 2024 Lancet Commission on Dementia Prevention has just released some critical new findings. So today, we're going to break down the updated evidence on two major systemic risk factors, type 2 diabetes and hormone replacement therapy.
So here's our game plan. First, we're going to tackle the new evidence on type 2 diabetes, really zeroing in on the age of onset and the role of specific medications. Then, we'll dive into the pretty complex data around hormone replacement therapy. And we'll wrap it all up with the key clinical takeaways you need to know.
Okay, let's get right into it, starting with a really crucial update on the link between type 2 diabetes and dementia. The Commission has actually reclassified this as a midlife risk factor, and that change is based on some significant new evidence about when the disease starts.
You see, for a long time, we've thought about diabetes as mainly a late-life risk factor for dementia. But the new evidence paints a much more nuanced picture, establishing that the age of onset, well, that's the critical variable.
This graph from the report really illustrates the new thinking perfectly. It plots the dementia risk against the age someone is diagnosed with type 2 diabetes, and you can see it clearly. The risk is highest for those diagnosed in midlife, and it systematically drops the later the age of onset. So it's really the midlife onset, not a late-life diagnosis, that's driving this elevated risk.
And the numbers on this are pretty precise. A large study of over 10,000 people found a hazard ratio of 1.24. Now, what does that mean? It means there's a 24% increase in dementia risk for every 5-year decrease in the age of diabetes onset. This effect holds true until about age 70, and then the risk seems to level off. This right here is the evidence that prompted the reclassification to a midlife risk factor.
Okay, so that leads us to the next logical question, right? If the onset of diabetes is so important, does treating it actually modify this risk? Well, the Commission's findings show that the relationship isn't so straightforward. It seems to depend less on how tightly you control glucose and more on the specific medication you use.
And the data reveals a really critical distinction. Evidence from randomized controlled trials shows that just aiming for intensive glucose control, that doesn't actually reduce dementia risk compared to standard care. But, and this is the interesting part, the class of anti-diabetic medication used is associated with very different outcomes for dementia risk.
This forest plot, which summarizes data from over 1.5 million people, shows these varied associations beautifully. Anything to the left of that center line indicates a reduced risk. And look what's there, GLP-1 receptor agonists and SGLT2 inhibitors. But if you look to the right, indicating an increased risk, you see sulfonylureas. This really suggests that the specific biological pathways these drugs target are a key factor.
All right, let's switch gears. We're now going to turn to a complex topic that's newly addressed in the 2024 report, the role of menopause and hormone replacement therapy, or HRT, in dementia risk.
The Commission is very precise with its wording here. Their overall conclusion is that it remains unclear whether HRT is causally related to dementia risk. So while a direct cause and effect link hasn't been established, new evidence from large-scale studies is revealing some pretty significant associations that we really need to look at.
So with that question of causality still up in the air, let's examine the specific risk associations that have been identified in recent large-scale studies. The evidence is telling us that the risk is not the same across all types or timings of HRT.
What we're seeing from large case control studies is that the combined estrogen-progestogen therapy is associated with an increased risk of all-cause dementia, a hazard ratio of 1.24. But here's the crucial part. This risk seems to scale with how long you use it. The longer the therapy, the higher the associated risk.
And there's more. The timing of when you start therapy seems to be significant, with worse risk profiles if you begin after age 60. On top of that, a meta-analysis of randomized trials also found a small but statistically significant negative effect on global cognition from any HRT use. And finally, we're now seeing high-quality evidence suggesting that even estrogen-only therapy may increase the risk of dementia.
So after reviewing all this new evidence on these two major factors, what does it all mean? Let's pull it all together and synthesize the key clinical takeaways from the Commission's report.
The report's conclusions can really be summarized in 3 key points. First, for type 2 diabetes, midlife is the critical window for dementia risk. Second, the choice of medication for diabetes is significant, with certain drugs linked to lower risk and others to higher risk. And third, the dementia risk associated with HRT is nuanced. It's linked to specific regimens, how long you use it, and your age when you start.
You know, this incredibly detailed evidence really moves dementia prevention beyond just a simple list of risk factors. It highlights the critical importance of timing, duration, and the specificity of treatments. So the central question that comes out of all this is, how can we evolve our prevention strategies to become more personalized and precise, targeting the right intervention for the right person at exactly the right time?